So as we are discussing about this new drug, most important thing we have to understand is that we are looking for an ideal antiplatelet drug for so many years. What we want from a drug is that it should have a good antithrombotic potential, and it should not cause much of bleeding. And it should act very fast. And if we want to stop the action, we can stop the drug and it quickly offset its action. Because there are some emergencies when patient may end up in a situation where emergency surgery is required, patient can have bleeding. So these are the major challenges in using an antiplatelet drug. So what we want is best of both worlds. The drug should be having very quick onset of action. So that as soon as we give it, within minutes it should act. We should not wait for half an hour or 1 hour or 2 hours, because patient in acute MI is coming to hospital and you have to treat them immediately. You need immediate action. You also need till the admission, what is the anatomy. You want to decrease the ischemic event during the angioplasty. You want a quick onset if there is some complication or patient has to go for surgery. So we have multiple drugs available till now, but no one was fitting into this ideal. Now, this first time Cangrelor has came, which was sort of fitting into most of the issues. Only thing is it is intravenous because we have to use it immediately. So the only thing is it's intravenous use, but this will be helpful in immediate action. So if we compare the 4 molecules, clopidogrel, prasugrel, ticagrelor, and Cangrelor, all are P2 vital inhibitor, receptor inhibitor. So the onset action of clopidogrel is 2 to 4 hours. So generally, this is very long. So the action starts quite late after giving it. Prasugrel is 1 hour, ticagrelor is 30 minutes. For Cangrelor, it is just 2 minutes. Offset of action, again, you can see 5 to 7 days for all these drugs. And for Cangrelor, it's just 60 minutes. Reversibility is there with ticagrelor and Cangrelor because they are reversible inhibitors. These two are permanent, though they take the platelets to be new platelets have to be degenerated before you can start it. You can feel that the action has gone. So platelet inhibition also in clopidogrel is not very robust. So it is 20 to 60%. So many patients are clopidogrel resistant, and still we feel that even after giving clopidogrel, there is thrombotic event like stent thrombosis or those kind of issues which angioplasty is always worried that patient should not have a stent thrombosis. So what we want is a good antiplatelet inhibition. So prasugrel and ticagrelor have much better antiplatelet inhibition. Platelet inhibition, Cangrelor has even better, 95%. In terms of dosing, we all know that clopidogrel to be given 300 or 600 milligram depending on the situation of patient. And for prasugrel, 60 milligram loading and 10 milligram daily. For ticagrelor, 180 milligram loading and 90 milligram daily. For Cangrelor also there is a loading and maintenance dose. The good part about Cangrelor, because it has a short duration of action, so it has a special use in dosing for bridging. So if you are waiting for a surgery to be done and you have to stop antiplatelet and you want that antiplatelet action, should they be there just before surgery so the chances of thrombotic events are less, like in a patient with a recent angioplasty, if has to go for an emergency surgery, either cardiac or non-cardiac, you have to stop antiplatelets and you are always worried that the stent may thrombose. So in those situations also there can be a use and the dose is quite different in those situations. So dose adjustment for age, for other issues, for weight is not required in this as in prasugrel. Contraindication definitely for all these active bleeding. There are no major drug interactions as such. So how we consider this molecule to be used in patients of ACS? So if patient is coming for an ACS in emergency department, then we have to assess the risk of the patient. If he's high risk or low risk, what is the ECG changes? What are the troponins? Is troponin rising or stabilizing? What are the issues in triage? Is it ruling out MI or is ruling in MI? And depending on the situation, we diagnose them. Patient is a non-cardiac or a cardiac patient. Cardiac have either an STMI or unstable angina or STMI. So then in these kind of situations, we have to decide on the basis of risk that he has to go for early invasive strategy or conservative strategy. And depending on that situation, we want to go for angiography and then take a call. So here comes the issue. If patient goes for angiography after giving a loading dose of both the molecules of P2 vital inhibitors and ecosprin, and if somehow angiography shows a triple vessel disease and patient has to go for surgery, then definitely they have to wait for a few days before the effect of the P2 vital inhibitor goes down. Then there are certain patients who are having heart failure and delayed bioavailability, and they have to go for immediate angioplasty, and we are giving clopidogrel, but action is quite delayed. There are patients who are coming with mechanical ventilation. There are patients who are having cardiac shock, heavy sedation, or morphine use. You can't give them oral medications. Or patient has active vomiting. Also, you can't give them oral medication. So there are multiple issues where there is an issue with the oral drug. So we are always in need of an intravenous drug which can be given safely and with even better results. So I will discuss just two cases. I'll not go into too much of theory. I will discuss two interesting cases, and then we will discuss few other uses of this molecule. So this is a 64-year-old diabetic hypertensive male presented with chest pain for 3 hours. He was having a gastric ulcer history and GI bleed 8 months back. ECG was almost like ST elevation kind of sign seen in inferior wall, but not very significant. There is AVL is showing some STTV depression. Troponin is high, although it's very borderline. He was uncontrolled diabetic. Hemoglobin is 11. This now. So no recent bleeding reported by the patient or black stool reported by the patient. Patient is a smoker. Echo in emergency showed mild hypokinesia, especially in LED territory, not in RC territory. So ECG and echo are not corroborative too much, and troponin is also very borderline high. So we were not very sure what to do. Now there is a history of GI bleed also. So risk was calculated for him, and TIMI risk score was calculated that age is less than 65, although he's 64, just borderline. There are multiple risk factors in this patient. Although he was not a known case of CAD, but recent ACS presented with angina. ECG changes are not very classical, but positive cardiac markers are there. So although ECG changes may be given as yes or no, because we are not very sure that they are new changes or they are old changes. But he was having 4 points with all these minimal parameters, and the risk is significant with this. So all these patients who are having significant risk factor like TIMI score more than 2, they should go for an early invasive strategy. Now in early invasive strategy, ideally what we do is we load with aspirin, and we also load with the ticagrelor or clopidogrel or before angiography, or even in triage. Generally, prasugrel is not used in triage, but in situations where we are worried about bleeding or some other issues or a risk of early surgery, then generally what we do is we load with aspirin and give them heparin also. And we don't give ticagrelor or clopidogrel in these kind of some special situations. Although this is not a standard therapy right now, maybe in future this may be a standard that you don't have to give this in triage, but still now the practice is that we generally load with double antiplatelet in triage only. But in certain situations, we choose not to give the second drug. So in this patient, only aspirin was given in emergency, and he was not given P2 inhibitors and shifted to cath lab. So this is the angiogram. So you can see with the echo showing hypokinesia and LED territory, and ECG showing some STT changes, subtle changes in RCA territory, and troponin positive patient has a significant triple vessel disease. RCA is a long diffuse lesion in a mid and distal part. LED is showing lesion starting from the ostium and very tight in the middle. Diagonal is showing a very tight ostial lesion, which is a significant large size diagonal and only diagonal. And ramus is also showing a tight lesion. So left main is trifurcating into C part. There is some lesion in the left main also. And then there is a trifurcation, which is a significant lesion. So here comes the issue. What should be done in this situation? Now we have a patient who has a history of GI bleed and gastric ulcers, and he presented with TVD in his diabetic and smoker with an almost normal LV function. So what should be done? What will be the best for it? So the best way to do it is to assess the risk score, because in this situation, we have to do angioplasty in the left main area with the bifurcation lesion, and a diagonal is also involved and RC is also involved. So best way to treat them is to assess the risk score and then plan. So we have assessed the syntax score, which is depending on the coronary complexity. So this came out to be 31, which is quite high. Anything more than 26 is considered high, and anything more than 32 is considered very high. So it's coming into intermediate range. Now they have updated the syntax score with multiple other parameters to assess the long-term outcomes, because now we have data available for the more than 10 years. So this is how this comes out if we assess the 10-year outcomes for this patient, in which there is a left main bifurcation involved, there is a LED bifurcation involved, and RC is also involved, and he's diabetic, smoker, and recent ACS. So 5 years risk of death with PCI is 20%, and 10 years is almost 28%. For CABG, it is 13 and 19%. So CABG considers above angioplasty in terms of indication. So it was discussed with the patient, and patient was okay with bypass surgery. So I have just forgot. So as soon as we have taken him in cath lab, we have started him on Cangrelor. I think I have written it somewhere. Yeah, so Cangrelor was started in cath lab. So Cangrelor dose, as we have already discussed, is to be given in a bolus and an infusion dose. So bolus was given, and then infusion was started, and then in the meantime, angiography was done. And all this discussion was going on, and already Cangrelor is already started. Patient was stable in cath lab, and pain has subsided. But definitely we have to plan for either angioplasty or CABG in this kind of situation. And patient finally agreed for CABG. Now, the good part about this drug is we can stop this drug and patient can go for surgery within even 2 to 5 hours or 6 hours of duration of stopping. So patient was planned. So it was in case done in, I think, almost 7, 8 p.m., 9 night. So plan was to do an CABG early morning next day. And Cangrelor can be started 5 to 6 hours before CABG. So this is the best part about this drug is that if you have to give it for a patient where there's a serious situation and you want to go for some kind of surgery, you can easily stop it and the action will go in 5 half-lives, which is 5 hours. So the half-life is just 1 hour. So in 5 half-lives, the action will be fully gone and patient go for surgery. So he went for surgery and surgery was uneventful and patient recovered. So this is one of the major thing here that this is a very short half-life. So whenever there is an issue about antiplatelet action and it is causing problem in surgeries or plant surgeries, this is a very good drug. So now it is tried even for the bridging also, like a patient with a recent angioplasty. He is on dual antiplatelet and now he's planned for emergency surgery. So you have to stop dual antiplatelet for at least 4 or 5 days. So for this 5 days time, you are worried about thrombosis. So what we can do is we can start this Cangrelor in an infusion dose as a bridging dose of 0.75 milligram. And then before 6 hours of surgery, you can stop it, and then patient can go for surgery. So that way you can minimize the risk of the thrombotic complications. Another important case is a 65-year-old male presented with complaints of acute chest pain and sweating and severe dyspnea. So he was from Hisar, and then they've shifted him, first evaluated there. They've also done an echo there, which showed a very poor LV function. So they said, we can't manage it, and he was shifted. And while in transport, he was having severe breathing difficulty, and he was on BiPAP support during transport, and immediately after shifting to Medanta, we have to intubate him. So he was having some history of cardiovascular illness 5 years back, but he was not properly investigated and just was on aspirin. He was diabetic, hypertensive, smoker also, strong family history. So on admission, he was having hypotension, cardiac shock. He was on high dose of iron drop, immediately intubated. ECG was showing generalized SCT depressions. So with this kind of situation and very low blood pressure, we have inserted IBP also. And this is the echo at the time of admission. You can see that heart is just moving. But the good part is that the thickness of the whole of the myocardium is fully preserved. You can see everywhere the muscle thickness is preserved. But ejection fraction is just 10-15%. There's just minimal movement of the muscle. ECG is not showing ST elevation, but some ST depressions. He is in class 4. So he was again taken for angiography immediately. Again, he was having just 15% EF. He was intubated. There was no rise tube at that point of time, so we could not load it properly. And he was on aspirin, so we have taken him immediately into the cath lab. The only advantage we are having is that we know that we are having Cangrelor on shelf. So if required, we can give it immediately, and that will start acting. So on the notion of availability of this new drug, we have taken him even without putting a rise tube in an intubated patient. So that was the best part. So there was no time delay unnecessarily for all these things, and angiography was done. So you can see here again, angiography is showing a RCA, which is almost 100% blocked, 99% mid, and then 100% blocked, filling retrogradely. LAD is after proximal part, diffusely diseased, calcified, a very long disease, almost 99% blocked. You can see multiple things, and you can see IBP there, and you can see the circumflex also is diseased. So this is like a ramus. There is a large ramus which is involved. So with this kind of situation, again, is a similar situation. Patient has a significant poor LV function and severe TVD. So again, as soon as he was shifted to cath lab, we have started Cangrelor infusion and bolus. And this is also important when we are starting Cangrelor. We should know that we have to give them a long-term oral therapy also. So that has to be started as soon as the Cangrelor infusion is over. So ideally, what is recommended is that Cangrelor should be given for at least 2 hours or for the period of procedure if it is more than 2 hours. And then you can stop it. And as soon as you stop it, you have to start either clopidogrel or prasugrel. Because they are permanent inhibitors, they have to be given after the procedure. If you want to give ticagrelor, ideally it is given after the procedure, but you can give it even during the procedure also, because the competitive inhibitor, there is no interaction with the molecule. So they have to be given in full bolus doses and then maintenance doses. So in this patient, it was planned because of emergency situation and because of so many issues in EF of 10-15% intubated. Generally, he was not a candidate for emergency surgery, so we have planned for an immediate angioplasty. Considering the serious situation, angioplasty was done in 54 minutes. Access was mainly femoral. 3 regulatory stents were placed. So both the arteries are ramus and LAD are fixed, and the RCA was left for the second sitting after once the patient recovered. So you can see now the LAD is almost fully stented from the proximal to distal part. There was a very tight region in the middle, and the ramus is also fixed with one stent. And patient recovered very well. So there was heavy calcification. So we have to do an OCT also, and you can see in OCT that there are multiple small, you can see some thrombus protrusion inside and some plaque protrusion inside. So these are the situations when patient is having highly thrombotic state. So in those kind of situations, we need a more potent antiplatelet drug, which acts immediately. Because if we are doing it and if we are given an oral drug, this may not, there is very high chance of slow flow, no flow, or stent thrombosis in the first 24 hours. So you can see there are some thrombus was also attached to the struts somewhere. So you can see there is some thrombus here. So I will just stop it and I will just show you. So you can see there is some thrombus here. Then there is some plaque protrusion here, you can see. So these are the patients who are in a very high risk situation. So you have to have this. So good part now is that he came at 1 month and patient is still on DAPT with statin, and we have given him Varni and SGLT2 and beta blockers, everything. And now he's not needing any diuretics, and ejection fraction has recovered significantly, almost 45%. Apex is still akinetic, but rest of the part is normal and patient is totally normal. From a 10 to 15% EF, he is fully recovered. So with this, I want to come to the uses of Cangrelor. That patient who is having high cardiovascular risk, so he has multiple risk factors, very poor LV. So in these patients, this can be given in patients, especially when the oral access is not available. Then this is a very good drug which acts immediately and which saves you in complex situation like this. And once the procedure is over, patient was loaded with ticagrelor. So why Cangrelor? So it is very important to understand that we need a drug which can act fast, which can be given intravenously, and on which we can rely on for the procedure. So this is a new drug which can be given intravenously if oral oral intake is not possible, like in our case. It was available in 2015 and approved for multiple societies like European and American and Japanese and Indian also now. So there are multiple trials done on this drug. So what they say is Cangrelor can be used during PCI along with aspirin in patients who have not received P2 inhibitors prior to PCI. So in our case, it was not feasible to give it. That's why we have not given it. So this was an ideal case. Otherwise, also in a patient, if you feel the risk is very high, if you feel that there's a very complex angioplasty and patient risk of complication during the procedure is very high, this can be given along with the aspirin instead of P2 inhibitors. Action starts within minutes, so you don't have to wait for half an hour for action to start. And if you want to stop the action can stop within minutes also. Multiple trials are done on this, Champion PCI, Champion Platform, Champion Phoenix. Although they have not proven superiority, they have proven equally efficacy along with clopidogrel, or mainly it was compared with clopidogrel, and they have proven that there is no increased risk of mortality or death. And Champion Phoenix even proved that if you calculate the MI area of myocardial infarction by rise in cardiac enzyme, it is significantly better in patients who are having Cangrelor as compared to clopidogrel. So that is the good part, that by using this drug in complex angioplasty, when the myocardium is significantly lower, like in our patient with a 15% EF, if we can reduce periprocedural myocardial infarction due to thrombus going into the distal parts, you can reduce that and you can prevent many more patients. This was used in real world also in multiple countries, in multiple trials, and shown to be quite effective. Now it is tried for a bridging therapy also, as I was discussing previously, that if patient has to go for surgery or if patient has to go for some procedure and he is on dual antiplatelet and you don't want to stop it immediately and you don't want to wait for 5 days for stopping this, then you can give this drug safely and this can be used. Multiple trials will be planned in future. So till now, it has not proven superiority in terms of hard outcomes, but it has proven superiority in terms of soft outcomes like area of myocardial infarction, rise in troponins. So this is as good as all our new antiplatelet drugs and really effective when we have to give immediately and we want immediate action and we can't give orally, and if patient has multiple high risk factors and we don't want to take chances. So with this, I want to conclude and then we can have discussion. Thank you.
Thank you, Nagendra. I think it was an absolutely wonderful presentation, and it really brings to the point that where we can use this drug. So, Tanmay, are there any questions, or we can just have some free floating discussion?
I've sent some question in chat box, sir.
Okay. So let me see. Can we use both tirofiban and Cangrelor in PAMI patients with heavy thrombus burden, no reflow, so flow? I think this is a very interesting question. And certainly you can. In fact, this is the only agent. Ticagrelor is the agent, as Dr. Nagendra also showed, that it can be started even while Cangrelor is on in the cath lab. And this is the only agent. Otherwise, with prasugrel and ticagrelor, prasugrel and clopidogrel, it is still not recommended. And now there are two studies which are going on, which are known as the SWAP-5 and SWAP-6. These are the two studies which are going on to see how do we move from one agent to another. However, there was a study which is known as CATENA study, Canteno-CATENA, basically Cantic study, which actually compared ticagrelor versus Cangrelor. In this, ticagrelor was given as a chewable tablet. It was crushed. 180 milligrams was crushed in powder and it was given. And it showed that definitely there was no increased complications of giving Cangrelor to these patients. And Cangrelor can be given to patients if tirofiban has already been given, but certainly not with prasugrel because we don't know the drug interactions. And also there is a inhibition of platelets, which can happen, which can lead to more bleeding complications. So the second question is, if failed thrombolysis by outside, but if we will do primary PCI, what's the good role of Cangrelor? What's the good role about in post-thrombolysis patient? Okay. So I think, with Nagendra, you want to answer?
So you can continue as I can add on. Why I have not heard the question clearly.
Okay, the question is, in a failed thrombolysis, in a rescue angioplasty, whether Cangrelor can be given or not. I think that is what it means.
So in a failed thrombolysis, definitely we must have given P2Y2 inhibitors also. Because generally for patients who are coming for acute MI and you are doing thrombolysis, you also give full dose of P2Y2 inhibitors also. So definitely with this kind of situation, and already 1 hour or 2 hours are over, so platelet effect is already there. So till now, there is no indication in these kind of situations. Either you load it with this and take them for primary. If you are giving them thrombolysis right now, there is no indication for Cangrelor as such.
I think, yes, we are right that, we don't have specific information about it, but logically it seems, because that, if this is a patient who has a failed thrombolysis, which means the patient has kind of a P2Y12, most likely clopidogrel, because most of the centers will give clopidogrel to these patients. Patients can be brought to the cath lab and angiography has to be done. Then decide whether you want to do an angioplasty then and there or not. And in case you want to do an angioplasty and you see a huge thrombus burden, then I think if the risk of bleeding is not high, if the patient does not have high bleeding risk criteria, then in these patients you can certainly give it. This is just my, it's the kind of a calculation for that patient, because we don't have clear guidelines on this. But definitely it can be used in these patients because they are high-risk patients in any case. They have a higher risk burden of failure of some primary angioplasty, because primary angioplasty does worst in failed thrombolysis patients. How long Cangrelor can be given as bridge therapy? Dr. Mahesh Chandra Pilibhit. Yeah, this is an interesting question, Dr. Mahesh. Basically, as we already discussed that in these patients, Cangrelor, once it is started, it has to be given as 2 hours of during the PCI or up to 2 hours. So you give it up to 2 hours. If the PCI duration was 1 hour, you can give up to 2 hours. But if the PCI duration is already 2 hours or so, you may not necessarily continue this. You can give the oral agent at that time and then stop the therapy once the procedure is over. So that is the way it is given as bridge therapy. And also, as Nagendra also showed, that in those patients where you have to, necessarily you cannot give a oral agent and the patient has to go for surgery, you can continue this for a period of time because the half-life is too short. So whenever you want to stop, you can stop. Dr. Gokhale from Bhopal, coronary angiography revealed osteal obstruction of RCA suspecting hypercoagulable state of the patients. I mean, as we have already discussed in hypercoagulable states, we don't know whether it is we are just contemplating. I mean, you are just thinking that it is a hypercoagulable state. But certainly whenever you see thrombus, whenever you see a bad lesion, especially in non-STMI or STMI, in these patients, there is a definite role. However, in the Champion Phoenix trial, actually 50% patients were actually stable angina, but they were high-risk PCI. So the interesting aspect of Cangrelor is you should know that this agent was actually introduced in 2009. The first trials were stopped. In between, the Champion PCI and the Champion this one platform trial were actually stopped prematurely because they thought that it is not going to make any impact compared to clopidogrel at that time. But now the Champion Phoenix trial actually showed that in the first 2 hours of intervention or PCI, these complications are reduced. And that is why this is a new thinking which has evolved that Cangrelor can be used in these patients. So that is where we are at this time. And we can use this agent thoughtfully and with all the data whichever we have, it should go. So primary PCI already loaded with ticagrelor. Can we give Cangrelor? Dr. Sanjeev Das from Kolkata. Dr. Nagendra?
Yeah, as we already discussed, that if you feel that you can't wait for 1 hour and you have immediately shifted to Cat7, you want immediate action, this is the drug. With ticagrelor, you can give it because only with clopidogrel, ticagrelor you can give it. You can't give it with clopidogrel or prasugrel, but with ticagrelor you can give it. So you are given ticagrelor, you can start it, and as soon as PCI is over, you can stop it, and by that time, the ticagrelor action will be started, so you don't have to worry about it.
So today, I think we must say that the safest agent to be given in the emergency room or in the ICU is ticagrelor. So that in case we are doing a primary angioplasty, it will help independently. And also, if we do a Cangrelor infusion in those cases, it will also be okay. So I think ticagrelor and Cangrelor are friends. Rest we will see in the SAFE-5 and SAFE and these two trials of swap trials. Yeah. So any other questions? I don't see any more questions here.
Yeah, one more question, sir. I received just now, sir.
I just see one from Dr. Barua from Guwahati. Can Canreal used as coronary intravenous? I really don't know. I mean, you can certainly use it as we have used the bolus therapies, and with all the 2B3As, we have used them as intracoronary also. So I don't know of any information. Nagendra, you know of any information on intracoronary?
There is no data till now. I think I have not gone through any data which they have used intracoronary. Everyone has used intravenous, and action is so fast within 2 minutes. So I don't think there is any need for that. As soon as you are planning for angiography, you can start it. You don't have to wait for angioplasty to start. And then if you want that is not be given, you can stop it. So that way, there is no need for intracoronary injection. You can start it, and in the meantime, you get angiography done and plan the plasty and discuss with the family. By that time, the action is there.
In fact, yesterday only I was doing a left main angioplasty, and soon after angioplasty, we started looking at some clots on intravascular ultrasound and OCT. So those are the kind of cases where the risks are running so high. We should use Cangrelor in these patients so that at least they can be immediately rectified.
So now the indication actually is mainly for those high-risk patients where you really think that thrombotic risk is high and multiple stents are to be used. There is heavy thrombus burden, heavy calcification, multiple stents are used, ejection fraction is low. So those are the situations where definitely it scores over all others. Otherwise, it has not proven any superiority of all others in a routine angioplasty.
Yes, absolutely. So as a antiplatelet agent, it should not be used for every patient, to reduce the risk. We have to clearly choose the patient, because we have seen, for the last so many years that everything comes at a price. So whenever we are treating ischemia, whenever we are treating thrombotic risk, we are also attracting bleeding risk. So the bleeding risk, although it is lesser than 2B3 inhibitors, let me tell you, there is a comparison which is available, which shows that the bleeding risk was higher with 2B3A, like this Tirofiban. The bleeding risk was higher, but definitely they could not show any significant difference. I think this was the faster trial, fabulous faster trial, which was comparing 2B3A versus Cangrelor, and it showed that there was no significant difference between the two agents, but the bleeding was high with 2B3A. So that is where it scores a little bit on, because many people may say that why use this agent? We have been using 2B3A for a long time, like Tirofiban or eptifibatide or even Riopro. But definitely 2B3A's the disadvantage is that they increase the risk of bleeding, which Cangrelor does not. That is the advantage. There is no significant major bleeding risk increase when you use Cangrelor in these patients.
Yeah, in the trials also it was shown that with comparison with clopidogrel, the bleeding risk increase was numerically high, maybe 0.7 versus 1.2, but it was statistically not significant. So there is no statistically significant bleeding risk increase as compared to clopidogrel by using this.
Yeah, that was also in the minor bleeding. In the major bleeding, there was no difference in that.
No change.
So this is the total summary of the whole thing, that this drug is.
One more question we have received. One more question from Dr. Amit Kolkata. They asked that, can Cangrelor replace GPI in near future?
In fact, today I must say that GPI is already almost the usage has come down by 99%. The usage has gone. Only 1% we were using 2B3A, especially the Tirofiban. Eptifibatide, I don't think whether they manufacture anymore or not. And Riopro also is almost, the company stopped manufacturing. The Eli Lilly stopped manufacturing Riopro already, which is Absiximab. Not at all. So the only agent which is left is this Tirofiban, and that too, the data is not so supportive as of now. Although these drugs were effective, but the net benefit was not there. So it is probably Cangrelor is going to fit into that space with less risk of bleeding.
No more questions, sir.
Okay, good. Okay, so I think we are already done. And so finally, I must say that this agent has been proven for many years now, and 25,000 patients have been studied. But we have to know that this has a niche usage in those patients where the risks are high, whether it is angiographic risk. Angiographically, the patient is high risk, as Dr. Nagendra showed, the syntax score is high. These patients, or those patients who are coming with non-ST elevation MI, ST elevation MI. In these patients, we can use it. And certainly, we have to be conscious of the fact that if the risk of bleeding is very high, then certainly one must make an informed decision about using this drug. It should not be used rampantly for any patient. Okay. So I think I'll stop here. If there is any other last point, Nagendra, you want to say?
I think so. You have summarized very well that this is a drug which is to be used for high-risk patients, and you should know the advantage is that it has a very short half-life. So if there is any major issue like bleeding and all, you can easily stop it, and the effect will be reversed within a few hours. So there is no need for an antidote. So that way it is quite safe. And in patient, you can't give an oral medication. This is the ideal situation when you can give it. So, and for bridge also, as we have discussed, that if patient has to go for surgery and you want to bridge it for some time, then you can give it. So there is very niche uses that very high risk patients, patients without oral intake, patients with bridge to surgery, all those kind of situations, this is a very good drug and with very safe and very easy to manage because you can stop it and the action will go away. You don't have to wait for days for action to be weaned off.
Quick action.
So,
okay.
Thank you so much. Thank you, Dr. Praveen, Dr. Nagendra sir, for this nicely presented today's case and the clearing or all the doubts for the other audiences. We are as a company, we are trying to bring down the Indian patient suffering by launching its various new molecule to the Indian market. From last 10 years, we have launched in various therapy, almost 17 molecule. The molecule was not available in India in different therapy segment, maybe in the cardiology, anticoagulant, or maybe in the pulmonary hypertension, or maybe in the diabetology. So in anticoagulant therapy, if you see, we have right now we have brought this Cangrelor, and before that we have brought to the Indian market that is the indigenous brand of the ticagrelor. First, we have this concept. We have Indian ticagrelors who have conceptualized in Indian market. Then a team of scientists who have worked to develop making the ticagrelor in the process. We have brought the pilot batch, then we have brought the commercialized batch. And the core team, they have struggled together to manufacture this. And at the last, you have the ticagrelor, the brand name is TRA, we have manufactured in Indian market, which has been also manufactured in USFDA approved plan in Hyderabad, sir. So in our anti-platelet therapies, if you see, we have brought this TRA kit, and presently we have brought this Canreal cell. So we may be the younger player, but our tribe and enthusiasm are the best in associating with you. So thank you so much. Thank you for enlightening the knowledge of all the audience who have participated in today's program, sir.
Thank you.
Thank you very much.
Thank you, Dr. Nagendra. Thank you. Thank you to all. Good night to everybody.
Thank you.